Good morning, Dr. Sanjay Jain, sir.
Hello, sir. How are you?
I'm doing good. Can you hear me, sir?
Sir, please close to mic. Sir, please close to mic. Unmute your mic, sir. Please unmute your mic.
Dr. Muthukumar, sir.
Yes, I have unmuted my mic. Are you guys able to hear me?
Yes, sir. Yes, sir. We are able to hear you. Are you able to share your screen, sir?
No, it's not letting me share. It says you cannot share screen while the other participant is sharing.
I think just I make you co-host or like this.
Now you can share, sir.
Yes, sir. Now the screen is visible now.
Go ahead and start the session.
Actually, we are waiting for one more chairperson, sir. Dr. Sarasu from JIPMER. Once she joined, we'll start, sir.
Morning, Dr. Sanjeev. I hope you're doing great.
Sir, during your introduction, we will share our slides. After that, you can share.
Sure.
Okay, sir.
Which one, sir?
No, sir, we will share the intro slides. After that, Dr. Muthu will share your presentation slides.
Yes, sir. Actually, first I will introduce chairperson.
Yeah,
So the chairperson will introduce guest speaker. Then
Right.
sir will start the sessions.
Yes. So Dr. Sarsu has joined. We can start now.
Okay, sir. Shall we start, sir? Okay.
Yes, sir.
So very good morning to one and all. This is Dr. Sudhakar, Associate Professor from Department of Anatomy, AVMC. So on behalf of organizing team, AVMC, BMSCON 2022, I welcome our guest speaker, chairperson, and all delegates to the first talk of second day scientific program. Before starting the session, I would like to introduce our chairperson. Sir, not this slide, sir. First one. I would like to introduce the chairpersons, Dr. S.K. Jain. Please, sir, PowerPoint. Yeah. So it's my pleasure to introduce the chairperson, Dr. S.K. Jain, Vice Dean, Professor, and Chair, Department of Anatomy, Tirthankar, Mahavir Medical College and Research Center, Moradabad, India. Sir has completed his graduation and post-graduation from GSBM Medical College, Kanpur. Sir has been more than 25 years of teaching experience, both in government and private sector. Sir has conducted many international workshop and conference, which includes international workshop of anatomy as organizing chairperson in 2021. Also conducted National E-Anatomy Conference as organizing chairperson in 2021. Also founder, chief editor, University Medical Journal, Acta Medica International. Sir has also conducted National Conference of Anatomy as organizing chairperson on virtual versus explicit opportunities and challenges in 2021. Sir published more than 70 research publications in both national and international journal of review. Sir, we'll welcome you, sir.
Thank you. Thank you very much, sir. Thank you very much.
Next, I would like to introduce the chairperson, Dr. Sarasu J, Professor, Department of Anatomy, JIPMER, Puducherry. Ma'am is also faculty of in charge of cytogenetic lab. Ma'am completed MBBS, both MBBS and MS from JIPMER, Puducherry. Ma'am is also completed PGD MLE, that is Postgraduate Diploma in Medical Law and Ethics from National Law School of India University. Ma'am also completed DPT Fellowship in Genetic Diagnostics. Ma'am has been more than 15 years of teaching experience. Under his professional achievements and awards includes faculty in charge of cytogenetic lab and molecular genetic lab. Ma'am also accreditation coordinator of JIPMER, member secretary accreditation group of JIPMER Quality Council. Ma'am is also NABH assessor for hospital, NABH auditor for medical lab, then member secretary and the executive member of many institute constituted task force, workforce and committees. Ma'am also organized many conferences and workshops, which includes hands-on training in basic karyotyping technique, JIPMER Quality Council accreditation workshop, and patient care safety. We welcome you, ma'am.
Thank you.
Now I request chairperson to introduce the guest speaker.
Thank you. Will you please share the screen?
Yes, sir.
I am very happy to introduce a very eminent personality, that is that Dr. Muthukumar Shakthivel, who is presently the co-director of Cardiovascular and Thoracic Imaging at University of North Carolina at Chapel Hill. He did his MBBS from AVMC Medical College, Puducherry. He also did DMRD from Raja Muthaiya Medical College, Anomalous. He did his TNB from KG Hospital, Postgraduate Institute, Coimbatore. He is also clinical fellow in cardiothoracic imaging from Department of Radiology and Imaging, University of North Carolina at Chapel Hill. He is currently the co-director of Cardiothoracic Imaging Fellowship, Graduate Medical Education. He is also the imaging co-director for UNC Lung Cancer Screening Program. He also served as co-director of the Cardiothoracic Imaging course for UG Medical Education, University of North Carolina at Chapel Hill. He presented more than 10 national and international level of the research publication and also contributed chapter in the molecular mechanisms of SARS-CoV-2 influenza and other lung infections. He is also having the memberships in the Radiological Society of North America, North American Society of Cardiac Imaging, American College of Radiology, American Roentgen Ray Society, Society of Cardiovascular Computed Tomography, STR and SCMR. And he received the Best Resident Research Award Award of Academic Excellence in Radiology Residency and Best Resident Teacher Award. Sir, it's my pleasure to welcome you in this BMS International Conference. And if the organizing committee permits, you may start your lecture, please. Most welcome.
Thank you very much for the kind introduction, Dr. Sanjeev. It's a pleasure to be introduced by such an eminent personality, and I wish all the very best and best of luck for the BMS conference, and kudos to the BMS organizing committee for scheduling this conference. As Dr. Sanjeev said, my name is Muthukumar Shakthivel. I'm a radiologist, and I specialize in cardiovascular and thoracic imaging. I'm going to share my screen now. Is everyone able to see my screen?
Sir, sorry for the interruptions. Your audio is very low, sir.
Can you check how is now? Is it clear?
Your screen is visible, but the audio is very low, sir. But previously it was good.
How about now? Can you hear me clearly?
Yes,
now?
sir. Yes, sir.
So
Now
I
you
think
are.
that-
Yes, sir.
I'm
Now
sorry.
you are audible, sir. No problem.
And I just checked and rechecked the mute icon. It worked again. That's good. All right. So,
Your voice is now loud and clear, sir. Carry
all
on.
right.
Sir.
Good morning, everyone. My topic for today's discussion is role of CT angiogram in diagnosing anomalous vascular pattern of heart and its branch vessels. This is the hospital I work. This is where all the magic happens. Greetings from UNC. I'm a proud alumni of AVMC. I'm grateful for the opportunity provided by the BMS team to address my alma mater. And my goals and objectives for today's lecture is to review the imaging techniques used in the evaluation of branch vessels of heart, and discuss regarding the role of non-invasive imaging in evaluation of cardiac vasculature. And we will round off the session with a case discussion about 8 different cardiovascular cases which are associated with anomalous as well as congenital heart disease. What is angiogram? Angiography is the study of blood vessels. Angiogram is the technique to produce images of the blood vessels. There are different types of angiograms: catheter angiogram, CT angiogram, and MR angiogram. All 3 types of angiogram requires injection of contrast, or also known as dye, into the vascular territory through either arterial injection or through venous injection. Predominantly in catheter angiogram, we use right femoral artery for injecting the contrast. And then we will put the patient in the fluoroscopy table, and we will take dynamic x-rays where the x-rays run in cine loop, and then we will image the patient. In CT angiogram, we use intravenous injection. We will inject the contrast through the vein, and then we will image the patient via the CT. In MR angiogram, we will inject gadolinium, which is a special type of contrast agent, which is used for MRI, and then we will put the patient in the gantry and we will image them. So today we are going to discuss about the importance of CT angiogram in the cardiac vasculature. I will briefly touch upon catheter angiogram, why, when and where it is indicated, why it is used, and why CT angiogram is better than catheter angiogram for diagnostic studies. And we are not going to discuss about MR angiogram today. What is catheter angiogram? As I already discussed, so the patient comes in into the fluoroscopy suite, and he will lie on the fluoroscopy bed. Most often it is used by interventional radiologist and interventional cardiologist. We use the femoral artery. We make a femoral arterial puncture, and then we will inject the contrast through the femoral artery, and then we will inject a catheter. Once we reach the site of target, we will do our interventions. So as a diagnostic procedure, angiogram can be helpful in detecting blood vessel disorders like aneurysms, bleeding, and malformations. In patients with cerebrovascular incidents, you can see there is a blockage of blood flow to the certain region. When we reach that vessel target, then we have use vacuum techniques to evacuate the clot as a therapeutic. In patients with subarachnoid hemorrhage, we will go and coil the aneurysm. In patients with GI bleeding, we will block the local blood vessels so that the bleeding can stop. So this is a patient of mine. He came to me 2 years ago through ED when he had severe chest pain, and he ended up having an aortic dissection. So we did a fluoroscopy, and we put a large bore stent, which is a metallic stent which extends from the aortic arch to the descending thoracic aorta. A couple of months ago, he again presented with severe chest pain in the ED. So we did an CAT scan. We couldn't find anything, but in order to assess the stent integrity, they asked me to do an angiogram. So this is the video of that angiogram. As I already told you, this is this metallic embossed region. This is the stent, and this cobra-shaped head this is the cobra catheter. We will inject contrast through the catheter. Sorry about that. So this is where the contrast is injected, and you can see the contrast outlines the lumen of the aorta. So what is angiogram is nothing but a luminogram. You are able to see the abnormalities within the lumen, but you will not be able to see the vessel wall or the other accessory structures like ribs or other accessory structures like lung or other tiny veins. So you will be able to image only the vessel of interest. That's why it is very effective in used as a therapeutic as well as a diagnostic. But in order to rule out other causes of chest pain or other causes of patient symptom, angiography is not effective. So I injected contrast through the patient, and I'm able to see some focal dilatation within the stent region. That means the stent is integral, but there is a focal re-expansion of the aneurysm or the dissection which is lying there. So we have to repeat an angiogram, and then we have to see how the management of the patient is being done. So this is basically the procedure of conventional angiography. So what is CT angiogram? CT angiogram combines a CT scan with an injection of a dye to produce cross-sectional images of blood vessels and tissues in a part of your body. The dye is injected through IV line started in your arm or hand. So remember, catheter angiography is done through artery. CT angiography is done through veins. So this is a patient who had a 48-year-old male who had severe chest pain. He had prior history of dissection. So he presented in CT with shearing chest pain and high blood pressure around 200 or 120. It was very high. So we ended up doing a aortic dissection study. So right off the bat, you can able to see the liver, you are able to see the aorta, you are able to see the bones, and you are able to see the kidneys, the rest of the heart, as well as the lungs. In catheter angiogram, you can only see the lumen, whereas in CT angiogram, you can look every other structure. So even if the study of interest is negative, you will be able to find other causes of the patient's symptom, and sometimes you will find incidental findings. For example, in this patient, the question was, the patient had a high blood pressure, whether he is having dissection or not. As we scroll through, this is the abdominal aorta, which is bifurcating in iliac. You can see that linear line, which is extending all the way up. And it is extending in the renal artery bifurcation, and it is also extending all the way above until the level of proximal abdominal aorta. So this patient indeed is having a dissection, but apart from that, there are a couple of important findings you are able to see here. Look at the kidneys. Look at the kidneys on the right, and look at the kidneys on the left. This is the right side because liver is here. So this is the right, and this is the left. You can see there is a perirenal hemorrhage, and there is part of the kidney is infarcted. That implies that dissection flap has involved the origin of renal artery. these kind of findings cannot be identified on an angiogram, whereas on a conventional angiogram, whereas on a CT angiogram, you will be able to find these, you will make these findings, which will help the clinician to manage the patient better. And also, this patient is having innumerable amount of fibroids, which are very large, and this kind of fibroids can undergo necrosis, and the patient may end up having severe abdominal pain. So with this study, we are able to find there is a aortic dissection, and we are able to prognosticate that the patient is having a renal arterial involvement. So that also needs to be addressed. And also we are found out the patient is having large amounts of pedunculated and necrotic fibroids, which may potentially cause the patient severe abdominal pain. So this is a technique called volume rendering technique. What will happen is you will inject the contrast, and once the hyperdense structure, once the aorta enhances, we can color code the enhancement by giving different colors. In this patient, this yellow colored structure is your aorta. You can see the linear line extending from the juxtaductal region, which is just distal to the subclavian artery, and extends all the way down into the abdominal aorta. And you can volume render it. So the advantages of volume rendering is the clinician, if he decides, the clinician or the surgeon, if he decides to open the patient to do a surgery, he is already having a roadmap of what he's going to visualize. So he didn't need to guess. He knows what he's going to see. He knows whether the renal artery is involved or not. He knows exactly where to start the graft and where to end the graft. That's the advantage of CT angiography. It is diagnostic, prognostic, and guides us a roadmap. Whereas CT angiogram, it is just like, point of interest. You can do therapeutic, it is great. For diagnostic, it is very difficult. So this is another technique called volume rendering. You can see the bones can be seen, and if at all someone is trying a percutaneous procedure, this can act as the level where the abnormality is seen. You can see this is the aorta, this is the bones, which is volume rendered. So conventional versus CT angiogram, as I already told you, the advantages of conventional angiogram is it is both diagnostic and therapeutic, but the disadvantages, you need highly skilled personnel because it's it's very, trust me, it is very difficult to put an aortic stent, and it has more radiation dose because the patient has to lie in the fluoroscopy suit for a long time. It is invasive. Why it is called as invasive? Because we are going through a femoral artery, which is a normal structure, and when you go through a pulsating structure, it is always associated with complication. The common complications include femoral arterial pseudoaneurysm. When you cannulate a small vessel, you are at risk for rupturing the vessel. It is just a luminogram. As I told you, cannot assess the rest of the structure. As like every angiography study, you have to deal with contrast. CT angiogram, the advantages are least invasive, less radiation. The other soft tissues and organs can be assessed. It is extremely quick. And the cons are contrast allergy, just like any other angiogram. So before starting the cases, this is the monotone for this. That's like Swiss cheese model. The idea behind is one hole leads to multiple holes. This same thing can be applied to human embryology. One defect can lead to multiple defects. There is a saying in radiology called satisfaction of search. When you find the first finding, you should always start looking for the second finding. My teachers always say the second finding is the most difficult finding to make. So, if you see one abnormality, you have to start looking for other abnormalities. So they always say face is the index of the mind. I say blood vessels are the index of your heart. If there is something anomalous in your blood vessel, you should always take a close look at the heart because it will always be associated with certain types of anomalous vessels. So one hole leads to multiple holes, always remember. So this is the case number one. It is a 45-year-old male with history of ventricular tachycardia. He undergoes a cardio defibrillator replacement by the cardiologist. A post-procedural chest radiograph was obtained after the defibrillator was placed, and it was submitted for interpretation. I got a call from the cardiologist saying that, hey Muthu, can you look at the radiograph? I think there is abnormality within the pacemaker course. So for every a defibrillator replacement, we do a chest radiograph just to rule out pneumothorax. In this patient, the pacemaker, the AACD was placed. But before going into the radiograph interpretation, I want to review the normal central venous course. So this is your left internal jugular vein. If you place any catheter within the internal jugular vein, which is focused on going to the heart, so it has to come like this: internal jugular vein, and it has to go into the brachiocephalic vein, and then the right and left brachiocephalic vein joins together, forms the SVC, goes into the right atrium, and goes into the right ventricle. So if you put a central venous catheter, it has to come inferior, cross the midline, again goes inferior, and again goes inferior, then it goes to the left side. In our patient, in this radiograph, you can clearly see the pacemaker lead was placed to the IJV. It goes above the clavicle, and it is going inferior, but it is not crossing the midline. It just goes straight down, but it is somehow reaches the right ventricle. On a chest radiograph, the right heart border is formed by the right atrium. The left heart border is formed by the left ventricle. The right ventricle is the anterior most chamber, and the left atrium is the posterior most chamber. So when you are seeing an opacity right in the middle, when you're seeing the AACD right in the middle, so we are suspecting it is in the right ventricle, but it hasn't followed the normal course. The most difficult part in these kind of radiographs is they want to rule out aortic placement. So we ended up getting an angiogram. So this is the angiogram. You can see the pacemaker is on the left side. And you can see a blood vessel, which is adjacent to this is the aorta, this is the main pulmonary artery. There is a blood vessel, which is coming inferior. It is supposed to cross the midline, and then it continues as SVC into the right atrium. But in this patient, it continues inferiorly, keeps on continuing, and then it joins a dilated vessel, which when traced back, goes into the right atrium, and then into the right ventricle. So what is this vessel is? So there is a vessel which is coming lateral to the aortic arch, going and joining into the coronary sinus and going into the right atrium. So this is a left-sided SVC, which is joining with the coronary sinus, which goes into the right atrium and then goes into the right ventricle. That's the reason why the pacemaker, in spite of putting it in the left IJV, it somehow went into the coronary sinus and then it go to the right atrium and go to the right ventricle. That's the anatomical abnormality here. Sorry. So this is the abnormal anatomy. So once you put in the IJV, that goes into the left SVC, instead of crossing the midline, it comes down, goes into the coronary sinus, goes into the right atrium, goes into the right ventricle. That's what you are seeing on the radiograph. So persistent SVC is the most common congenital thoracic venous anomaly. It is often the first clue to this anomaly is unexpected course of a central venous catheter, a pacemaker, or in our patient, it is an AACD. The left SVC arises from the confluence of the left subclavian and jugular veins and transverses caudally. Persistent left SVC should be suspected when a dilated coronary sinus is seen on the cross-sectional imaging. Usually persistent left SVC is not associated with abnormalities. Sometimes it can go and drain into the left atrium, which can result in right to left shunt, and that is called as Ragib syndrome. So this is a second case. It's a 14-year-old male presented to the clinician with a history of difficulty swallowing large pieces of food. The barium swallow was done. It was inconclusive, except for a small indentation on the posterior esophagus. The astounding ENT surgeon was very smart. He ordered an angiogram to look for anomalous vessel. So we did the angiogram, and this is the CT scan. And this is your aortic arch, which is on the left side. And normally there should be no vessel or no structure going posterior to the esophagus. This oval-shaped structure is the trachea. This collapsed structure is your esophagus. And behind that, there should be vertebral body only. Nothing should go, no vessel, no veins, nothing should go. In this patient, there is a vessel which is coming from the aortic arch, going behind the esophagus. But by what we are seeing, it produces a remarkable indentation of the posterior margin of esophagus, which goes well with the barium finding we saw. So this is an aberrant right subclavian artery arising from the aortic arch. So this usually does not cause symptoms, but in some patients, it will end up producing a compression on the esophagus, and it results in a condition known as dysphagia Luzario. And this is the short embryology tips. So this is normal embryological arch, right arch, left arch. This is the right brachiocephalic vein, left common carotid, and left subclavian. Normally, in evolution, the right aortic arch involutes, and then you will end up normally having a left aortic arch, left subclavian, left common carotid, and right brachiocephalic. In patients with left aortic arch with aberrant right, the part of the aortic arch between the brachiocephalic and the subclavian involutes, leaving out the subclavian artery arising from the opposite aortic arch. So the left aortic arch with the aberrant right subclavian is asymptomatic, as I discussed. Approximately 10% of adults with this anomaly have symptoms of dysphagia resulting from extrinsic compression. They may occasionally have dysphagia. Some people, young adults, when they are growing up, they may have this kind of dysphagia symptoms. This is the third case. This is a very interesting one. It is a 25-year-old college football player presented to his team doctor complaining of repeated choking sensation, throat pain, difficulty in swallowing, and occasional chest discomfort. A chest radiograph was performed and it was submitted for interpretation. So right off the bat, you can clearly see from this radiograph, there is a large aortic knob. But what's weird about this radiograph is the aortic arch should come down on the left side, whereas in this patient, the aortic arch is going on the right side. So what I was suspecting is there may be an aneurysm sitting there. There is a right aortic arch. There may be some aneurysm sitting there that might be causing the patient symptoms. On the lateral radiograph, this is the opacity. You can see how much the trachea is pushed anteriorly. The trachea should normally come down straight line. In this patient, it is pushed anteriorly, this lucent line. So we were thinking, okay, there is an aneurysm that is compressing. So let's get a CT angiogram. So to our surprise, what we saw is there is a right aortic arch. There is an aneurysmal dilatation. It is not from the normal vessel. It is an aberrant, right? It's a right-sided aortic arch with aberrant left subclavian artery, and the aneurysm of the left subclavian artery is seen. You can see how much big the aneurysm, how much big this aneurysm is, and it is also thrombosed. So when there is an aneurysm of the aberrant subclavian vessel, it is called as comoral diverticulum. So this is what we saw on the X-ray. This is the maximum intensity projection in the CT angiogram. You can see how the aorta is tortuous, and it is seen on the right side of the heart, and then it comes down and becomes the abdominal aorta. And this corresponds to the aneurysm which we saw on the axial section, and this is the thrombosed part of the aneurysm. So this is known as a comoral diverticulum. So as I told you, as the embryology of the aberrant left with the right subclavian in this patient, the part between the left common carotid and left subclavian involutes, leaving the aberrant subclavian is to arise from the right side. So right aortic arch with aberrant left subclavian, the vascular ring is often relatively loose. This anomaly is rarely associated with congenital heart disease. When I see this, I won't be raring to go to look for congenital heart disease, but there are certain findings which will point you towards that. This is a different case. It's an interesting one. It's a 4-year-old male with history of recurrent UTI and pyelonephritis, presented to the pediatrician with persistently increased blood pressure, and more concerning was the presence of a newly documented murmur and difficulty in palpating femoral pulses. So the giveaway in this history is the newly documented murmur, increased blood pressure, and most of all, there is difficulty in palpating femoral pulses. This history itself prompts you to go and search for aortic abnormalities. So we straight away ended up doing an angiogram, that is CT angiogram. So this is a CT angiogram, sagittal reconstruction. This is like the lateral radiograph. You are seeing the patient from side. This is the right ventricle. This is the left ventricle. From the right ventricle, the pulmonary artery arises. The right ventricle is the anterior-most chamber, and there is the left ventricle. From the left ventricle, aorta arises. This is your pulmonary artery. So this is the descending thoracic aorta. This is the aortic arch. Right at that point, distal to the origin of subclavian artery, there is a focal narrowing. So this is a patient with coarctation of aorta This is where CT angiography supersedes over every other modality. We are able to perform a virtual reconstruction. This is called 3D volume rendering, where we isolated the aorta and then we provide this, we made this beautiful images. As I told, one hole leads to multiple holes. In this patient, the right side, the left sided common carotid, instead of arising as a separate branch, it arises along with the right brachiocephalic. This is known as bovine aortic arch. Along with that, you can see this is the aortic sinus, ascending aorta, aortic arch, left common carotid, left subclavian, right hand there next to the left subclavian. This is called as juxtaductal region. There is a profound narrowing. This is known as coarctation of aorta. And there are certain conditions which may mimic coarctation of aorta, but all those conditions won't have this dilatation just distal to the coarctation. You can see the caliber of the vessel proximal to the stenosis, caliber of the vessel distal to the stenosis. So it is enlarged and there is a narrowing. This is a patient with coarctation of aorta. And we were able to perform these beautiful volume rendering images. As I already told, one hole leads to multiple holes. You can see there is a trachea. We are looking for any other, tracheal abnormalities or situs abnormalities. That's the reason we did this volume rendering. And this is where CT angiography stood out against all of the structures. So aortic coarctation is defined as focal, discrete, constricted aortic segment, usually in juxtaductal location. There's a relatively common anomaly that accounts for 4 to 8% of congenital heart defects. Coarctation may occur as an isolated defect or it is associated with other lesions. When you see a bicuspid aortic wall, you should always check for aortic coarctation. When you see an aortic coarctation, always check for bicuspid aortic wall because it is most commonly interrelated, and also check for VSD. It is almost always seen in patients with left-sided aortic arch, not with the patient with right-sided aortic arch. This is a 2-year-old female presented to the clinician with findings of failure to thrive and growth retardation. A chest radiograph was obtained. And this is the heart, and you can see the pulmonary artery, and there is a lot of shadows going. This is too much for a 2-year-old kid to have this much amount of vasculature. When we see this much amount of vasculature in a patient who is not on heart failure, you have to think of congenital heart disease. This can happen only in volume overload status, or it can happen in heart failure. If not, that is an underlying congenital heart disease which has never been addressed. So we went ahead and did a angiography. So this is the level of pulmonary arteries. This is the right pulmonary artery, left pulmonary artery. As we scroll down, this is your right atrium. This is the left atrium. So this is the left atrial appendage. This is the right atrial appendage. Right at this level, there is a nice communication between the left atrium and the right atrium. So an interatrial septal defect occurring at this location is called a sinus venosus, superior sinus venosus ASD. When you see a superior sinus venous ASD, you should always check for anomalous pulmonary venous connection. Normally, the pulmonary vein drains into the left atrium. In this patient, the pulmonary veins on the right drains into the right atrium. The pulmonary veins on the left drains into the left atrium. So this is a patient with partial anomalous pulmonary venous return. So when the clinician is trying to operate on this patient, we have to give them beautiful volume rendering images so that they know where to dissect and when to, which location to dissect. So this is the pulmonary veins coming from the right side, and it is going into the right atrium. This is the pulmonary veins coming from the left side and going to the left atrium. So in normal people, you expect all the pulmonary veins to join the left atrium. In this patient, right-sided veins going to right and left-sided veins going to left. So there is increase in pulmonary vasculature, which resulted in dilatation of the pulmonary arteries and pulmonary congestion. So in partial anomalous pulmonary venous return, an anomalous pulmonary vein drains into a systemic vein rather than into the left atrium. The prevalence is 0.4 to 0.7%. It involves the right lung more than the left, and isolated right upper partial anomalous pulmonary venous return draining into SVC is the most common form and is often associated with sinus venosus type of ASD, as we saw in our case. This is the case number 6. It's a 3-year-old male presented to the clinician with history of multiple episodes of recurrent pneumonia. A chest radiograph was performed and submitted for the interpretation. Imagine if there is a kid who's normal and he's always getting recurrent pneumonia in a child which is less than 5 years old, you should always suspect some degree of structural abnormalities unless the patient is immunocompromised. So in this patient, you can see there is a anomalous blood vessel coming from below the diaphragm and going and draining into the lung parenchyma. So this is called scimitar vein, also known as scimitar syndrome or pulmonary venolobar syndrome. In this patient, some of the pulmonary veins from the lower lobe goes down. Instead of going into the left atrium, it goes down and drains into the IVC, creating a right to left shunt. And this is always associated with hypoplasia of the ipsilateral lung, resulting in the deviation of the heart towards the affected. So you can see in this patient, there is no heart shadow. Definitely there is some abnormality here. That's why the heart is shifted over the side. So we went ahead and did a CT angiogram. Sorry about that. So we went ahead and did a CT angiogram, and you can, right off the bat, you can see the heart is grossly deviated to the side of abnormality. That means there is a volume loss over there. And then you can see a blood vessel, which is a sword-like, it comes like this, and then goes all the way and drains into the inferior vena cava, which is a suprahepatic IVC, and then it drains and then it goes. This is called as a scimitar syndrome. And the vein is called scimitar vein, and it is always associated with the pulmonary hypoplasia. And this is the same CT in lung window. You can see the vessel beautifully. And this is the lung, which is hypoplastic, and that is replaced by cystic air spaces. Scimitar syndrome is a rare vascular anomaly. An anomalous pulmonary vein is the draining vein for the part of the entire right lung. The anomalous vein may occasionally drain into the hepatic veins, azygos vein, coronary sinus, or into the right atrium. Varying degrees of hypoplasia of the right lung and associated aplastic pulmonary artery. This is why it is very important to do a CT angiogram, because you are not only assessing the blood vessel, you are also assessing the lung parenchyma. And that's why catheter angiography is not useful in diagnosis of these kind of congenital heart disease. And you can do a beautiful volume rendering, and the surgeon will know what degree of lung is lost and how much degree of vein is draining into the anomalous path. So this is the case 7, 1-day newborn male with neonatal bradycardia and congenital heart disease diagnosed on fetal echo, presented to the radiology for congenital heart disease evaluation. Since there is time is a constraint, I will straight away jump to the volume rendering images. So this patient is having a double aortic arch. You can see the aortic arch is coming here, the right and left, and then it forms a vascular ring, and it compresses the trachea and the esophagus, resulting in dysphagia. And you can see the volume rendering image, trachea, and the double vascular ring. So this is a patient with double aortic arch. So this is the last case, 11-day-old newborn with neonatal bradycardia and known cyanotic congenital heart disease, present for congenital heart disease evaluation. This patient is having a double outlet right ventricle. In this case, this is their aorta and this is your pulmonary artery. Both of these vessels arising from the right ventricle. This is known as double outlet right ventricle, which is a cyanotic congenital heart disease. We do this volume rendering so that the surgeon can pre-plan the surgery and he knows what to expect before going in and operating on this patient. So DRV is common congenital disease, which is involved both arteries arising from the right ventricle. And I hope I fulfill the objectives of reviewing the imaging techniques in heart and branch vessels and the role of non-invasive imaging. And we went through the case discussion with 8 different cardiovascular cases. Thank you, AVMC, for everything. The dream journey started here. And I'm very glad I had the opportunity to come back and share my thoughts about the CT angiogram in heart disease evaluation. Thank you.
Thank you so much, sir. It was really wonderful presentation. You beautifully explained all that anomalous vascular pattern of heart and its blood vessels with beautiful images and videos, sir. Thank you so much, sir. Over to chairperson, sir.
May I request Dr. Sarasu J to please ask some queries from Dr. Muthukumar Shakthivel.
So first of all, excellent presentation, and time was kept. We were worried about that. Thank you very much. And it was an eye-opener for all of us to see so many different variety of anomalies and how interpreted. I do not have a personal query. It was a beautiful presentation. But the thing is, like, can you tell me about the advantages and disadvantages of why we choose this and what's the age group in which it has to be considered for contraindication of CT angio and volume?
Background noise, but I will answer your question. So, it, long before, like 10 or 15 years before, the CT scans are done with heavy radiation dose. Now we are having very, very fast CT scans. For example, my coronary CT time is 0.3 seconds. Within 0.3 seconds, I can image the entire coronary system. Right now, I do CT angiography for patients who are newborn on day 1. So I don't have any restriction. If you have any congenital heart disease question, if a congenital heart disease was questioned on a fetal echo, which was during the OBGYN ultrasound, if they found there is a vascular link, they want to assess on day 1, I will perform the CT angiography. Right now, there is no contraindications except if the patient has proven anaphylaxis or proven contrast allergy. There is no contraindication. You can go ahead and do any question of heart disease, any question of vascular anomaly, you can do it.
Is there any possibility that it could miss some diagnosis? Is there any possibilities of something which because any CT angiogram is, followed by the regular angiogram in some cases, right? So is there any possibility of missing out this?
So a couple of things we can do while doing CT. There is a gating from prospective, retrospective. In prospective, I image only in particular RR interval, whereas in retrospective, I continuously image. So when I do retrospective, the dose is, can you hear me?
Please speak to the mic. You're not able to hear.
Can you hear me now?
Yes.
Yes, sir.
So the question is, I do 2 types of CT, prospective and retrospective. In prospective, I image in particular RR interval only. In that kind of cases, the doses will be very less, but the disadvantage is I cannot assess any dynamic abnormalities. For example, if you are looking for a flap wall, I cannot assess it. If I do retrospective, I will image through the entire cardiac cycle. I can make an image loop out of it, but the problem is the dose will be more because the CT scan is always on. But with this advent of high quality and very fast CAT scanners, even that is not causing significant amount of radiation dose. But usually I avoid doing retrospective on young kids because it will give heavy dose. And if that is the question, in dynamic cases, I will also always refer them to MR. It's way better, no radiation. You can assess for moving structures better in MR.
Thank you. Thank you. Over to you, sir.
So there are no queries in the chat box. So we conclude the sessions. Before that, I guess as a token of appreciations, we would like to honor our guest speaker, Dr. Muthukumar Shakthivel. Thank you, sir. Next, I would like to honor our chairperson, Dr. Thank you, sir. Next, I would like to honor our another chairperson, Dr. Sarasu. Thank you, sir.
Thank you, sir. Excellent organization.
Wonderful
And
session, sir.
yes, sir.
Thank you so much, organizing team, for conducting such a nice session. Thank you so much for keeping me one of your chairpersons. Thank you so much.
Same with me, sir. Thank you so much for inviting me, and it's an excellent session and wonderful organization. Thank you very much, the whole team.
I would like to say good luck to the rest of the team and good luck for the rest of the conference.